So guys, today we are going to discuss about the anatomy of breast. Breast or mammary gland is also known as a modified sweat gland. Talking about situation and extent of breast, situation is in the superficial fascia except the tail of spines. Tail of spines is nothing but the content of the axillary sheath. So is in the superficial fascia except the tail of spines. As you can see in this diagram, that's the breast, and it's the superficial fascia present over here, and that's the axillary tail of spines where the high percentage of breast tumors or cancers is susceptible. Foramen of Langer through the opening in the deep fascia. Breast is located in the superficial fascia, but through this foramen of Langer, it's basically the opening into the deep fascia. When talking about extent, it's from the second rib to the sixth rib, and also it's important to know that horizontally the lateral border of the sternum to the mid axillary line, that is, this is the sternum, this is the lateral border of sternum, and this is the axilla, and it's a mid axillary line through which it extends. Now talking about relations and structures of breast. So relations of breast, superficially it is related to the skin and superficial fascia, and then after that it is basically deep relation is through pectoral fascia. As you can see over here, that's the pectoral fascia, then next relation is pectoralis major, serratus anterior, and external oblique. So pectoralis major, serratus anterior, and external oblique are the muscles. If you can see over here, that is pectoralis major, pectoralis fascia, and the retromammary space, serratus anterior, and basically external oblique muscle. Next, retromammary space, that is the space behind the mammary gland. Can you see, this is the space behind the mammary gland. This space allows the free movement of breast over the pectoral fascia, as you can see over here, and traversed by lymph node and blood vessels, and breast prosthesis is placed over here. That is the place where the breast prosthesis is placed. This is the pectoralis major, then there's the pectoralis fascia. Next, the structures of breast, in which we have basically skin, stroma, and parenchyma. In skin we have basically nipple and areola. In stroma we have connective tissue, and in parenchyma we have basically glandular tissue. That's the skin component of breast. That's known as a nipple. Nipple is present on the fourth intercostal space and more constant in males, containing smooth muscle fibers, and it's very important that nipple erection is autonomic and richly innervated by sensory nerves. It is pierced by 10 to 15 lactiferous ducts. So it is innervated by sensory nerve and pierced by 10 to 15 lactiferous ducts. Then these are the tubercles of Montgomery. Then there's the areola, that is a blackish area around the nipple, that is, it's darkly pigmented, and it consists of sebaceous glands, prevent drying and cracking, and it enlarge during pregnancy. And they also contains this tubercle of Montgomery. Now next what we have is a parenchyma. Parenchyma is what? So as we see this pectoralis major, pectoralis fascia, then this is the parenchyma. Parenchyma is present between the septum and the glands, and it's absent in the nipple and the areola. Fibrous stroma forms the fibrous tissue, and glandular part is basically 10 to 15 lobules are arranged in a radial fashion, and near its terminal end, as you can see, these are the lactiferous lobule 10 to 15 which are arranged in a radial fashion, and near the end, terminal end, the lobules are dilated. These dilated spaces are known as lactiferous sinuses, and through the lactiferous sinuses opens up the lactiferous ducts. So these are lactiferous lobules, then there is a lactiferous sinuses open up into lactiferous duct, and what is there is basically, this is the basic structure of the parenchyma, and that's the skin and what we can say sebaceous gland and skin component of breast we discussed, and discuss about fibrous part, glandular part, and fatty stroma. So this parenchyma is basically made up of three parts, that is fibrous part, then we have basically fatty stroma, and the glandular part. Now next what we have is this blood supply of breast. Blood supply of breast, what is this? That's the subclavian artery, and this subclavian artery is divided by the scalenus muscle into three parts, as we saw. What is this? That's the basically the superior thoracic artery, which is the first branch of the axillary artery. Then what is this? That is thoracoacromial triangle, the second part of axillary artery, and that's the axillary artery. This is the lateral thoracic artery, superior thoracic artery, and thoracoacromial tract. This is the axillary artery, and lateral thoracic artery is second part of axillary artery. Now it's important to understand that is superior thoracic artery, then this acromial tract, that is the trunk, that is second part of axillary artery, and the lateral thoracic artery, all of them supply the breast. Then and basically talking about the subclavian artery, then this internal thoracic artery, that is internal mammary artery, is a major blood supply to the mammary gland. This is very important, that is internal thoracic artery is the major supply to mammary gland. It's the first part of subclavian artery. Next, the perforating branches of the internal thoracic artery in the mammary gland, in branches of the intercostal artery, that's the intercostal artery branches, and perforating branches of the internal thoracic artery and the mammary gland. Talking about lymphatic drainage of the breast, so that's the breast. These are known as the parasternal lymph node, because here is the sternum, and the lymph node beside the sternum are known as basically the parasternal lymph node. And what is these are the supraclavicular lymph node, and these are the infraclavicular lymph node or apical group of lymph node. This is the anterior group of lymph node, this is the central group of lymph node, and this is the lateral group of lymph node, and the posterior. So anterior, central, anterior, posterior, then we have basically the anterior and posterior, then we have these known as a central and lateral, such four groups. This is apical group of lymph node, and this is known as basically the supraclavicular lymph node, and these are known as the parasternal lymph node. Then talking about a lymphatic drainage, how exactly it occurs. Basically, the intercostal lymph node and parasternal lymph node. Intercostal lymph node is going to basically is drained by the drain the deeper aspects of the breast. Then the inner quadrant of the breast is, that is the inner quadrant of the breast, is drained by the parasternal lymph node, and the axillary tail of Spence is drained by anterior and posterior group of lymph node, and the outer quadrant is drained individually by the anterior group of lymph node. So outer quadrant is by anterior group of lymph node, inner quadrant is by the parasternal lymph node, deeper aspect of breast is by basically the intercostal lymph node, and axillary tail of Spence is drained by anterior group of lymph node plus posterior group of lymph node, both of them. And it's also important to know that these are known as the apical group of lymph node, and percentage of lymphatic flow, that is 70% of lymphatic flow is by axillary lymph node, which is most important. 20% is by parasternal lymph node, and 5% is by the intercostal node. Okay, so what happens exactly is that here it's important to know that from here the lymphatics go towards the anterior group of lymph node. From the anterior and the posterior group of lymph node, they all go to the apical group of lymph node, and further they have their own lymphatic drainage system. Then what next, what we have is basically direction of lymph flow. Outer quadrant, this all we saw. Next what we have is this lymphatic drainage of skin except nipple and areola. So what is this? Infraclavicular lymph node will drain basically the skin over the clavicle. Axillary lymph node, as I told, outer quadrant drainage, breast, nipple and areola. Then basically what happens is this one, inner quadrant, parasternal lymph node, lymphatic drainage from inner quadrant skin communicates across midline. Breast pathologies are bilateral in such cases. Along the parasternal lymph node, its breast pathologies are bilateral. They move to subperitoneal lymphatic plexuses. Through the subperitoneal lymphatic plexuses, these will basically move to the hepatic lymph node to the cause obstructive jaundice if any pathology occur. If it via the transcoelomic route, it will cause ovary to the Krukenbach's tumor. So basically, yeah, this is the lymphatic drainage pathologies. That is, on the subperitoneal plexus, if any pathology occur, it will move to the liver to cause hepatic jaundice, and to the ovary to cause Krukenbach's tumor by the transcoelomic route. Talking about clinical anatomy of breast cancer, one of the most common type of cancer in females usually arises from the epithelial cell of the lactiferous ducts. Very much important, as we saw in this diagram over here. That is, these are basically the lactiferous ducts. So these lactiferous ducts के epithelial से the breast cancer arises. So yes, it's from the lactiferous duct epithelial cell usually arises from the, and basically pathogenesis, cancer cells or malignant cells will infiltrate the basically suspensor ligament of Cooper, that becomes breast become fixed and immobile, and is a retraction of skin. And next is basically lactiferous duct fibrosis causes retraction of nipple, as you can see over here it has caused the lactiferous duct fibrosis. And next is basically superficial lymphatics obstruction will basically cause purely orange appearance. Can you see? That's the obstruction of superficial lymphatics. Then classical signs of breast cancer: nipple retraction, dimpling of skin, and orangish appearance, giving a purely orange appearance. So that's basically the cancer or malignant cell sign. What are the three signs? Retraction of skin and immobile and fixed breast. Then this dimpling of skin and nipple retraction and orange appearance of skin, and because of the purely orange appearance because of the superficial lymphatic obstruction. So here we completed about breast. Now we'll move to cubital fossa quickly. So now talking about cubital fossa. What is cubital fossa? Cubital fossa is this. As you can see over here, that's the humerus. What is this? This is known as a muscle known as a pronator teres muscle. That's the brachioradialis muscle. And the space between the pronator teres and brachioradialis muscle known as a cubital fossa. So can you tell quickly the diagram? You can see over here in much detailed form. That's the cubital fossa. That is the space between pronator teres and the brachioradialis. Can you see in this diagram? Can you see in this diagram clearly? Wait, I'll try to clear. Okay, much clear now than before. That's basically the cubital fossa. As you can see, this is what is this muscle? That's the brachioradialis muscle, and this is the pronator teres muscle. So what is the thing? Um, Medial boundary. Medial boundary is basically what? The lateral boundary of the pronator teres. Lateral boundary, medial border of the brachioradialis. Apex, meeting point of brachioradialis and pronator teres. And the base, imaginary line connecting the medial and lateral epicondyles. That are the boundaries. Talking about the roof of cubital fossa. The roof of cubital fossa again comprises of skin, superficial fascia, deep fascia. What is this? That's a cephalic vein. Cephalic vein, can you see, which passes through cubital fossa? That's the cephalic vein. And cephalic vein is also a content of axillary sheath. Basilic vein. So cephalic vein, basilic vein. Then basically what we have is a medial cutaneous nerve of the forearm, and we have the medial cubital vein. Can you see? That's the medial cutaneous nerve of forearm, medial cubital vein, and that's the bicipital aponeurosis. And we have basically lateral cutaneous nerve of the forearm. We have brachial plexus का median cutaneous nerve, lateral cutaneous nerve. Then we have the medial cutaneous, lateral cutaneous, cephalic vein, basilic vein, and also we have the medial cubital vein, and three veins. So you can say we have basically three veins. One is the cephalic vein, second one is the basilic vein, and the third one is basically the medial cubital vein. This medial cubital vein, and then we have two nerves. Mean what we have is the medial cutaneous nerve of the forearm and lateral cutaneous nerve of the forearm, and then we have one aponeurosis which is called as bicipital aponeurosis. And then what is next is basically this. This is cubital fossa, two muscles, cephalic vein, basilic vein, median cubital vein, as you can see over here, joining the two. And then we have this bicipital aponeurosis, lateral cutaneous nerve of the forearm, medial cutaneous nerve of the forearm. So three veins, two nerves, and one bicipital aponeurosis. That's the content of cubital fossa. Floor of cubital fossa, supinator muscle on the radius, and on the ulnar what we have is basically the upper end of radius. We have brachialis muscle attached to ulnar tuberosity, upper end of ulnar. What are the contents talking about? We have to remember mnemonic MBBS of the cubital fossa. What are the contents of cubital fossa? Those structure which we saw was basically the structure from the roof of cubital fossa. Content of cubital fossa: medial to lateral, will go medially to laterally. What is the medial most content? Median nerve. Can you see over here? So what will be this nerve called as medial to lateral medial most content? That's the median nerve. So I basically write over here that this is the median nerve. Can you see? Now again we have to move next part. What is it? We'll move to the next nerve is the run between superficial and deep head of pronator teres muscle. That's the pronator teres muscle. That's superficial head, that's a deep head, and in between the two runs this median nerve. Next one is the brachial artery. What is the brachial artery? Can you see this red one? Yeah, this red one is known as the brachial artery. That's the brachial artery. So median nerve, brachial artery, and what we have next is the biceps tendon. Can you see? That's the biceps tendon or bicipital aponeurosis we also can call it. So that's the biceps tendon, or we can also call it as a bicipital biceps tendon, not bicipital aponeurosis, sorry, it's a bicep tendon only. Then we have S, that is superficial branch of the radial nerve. That's a deep branch of radial nerve, that's a superficial branch of radial nerve. What is this? Again the superficial branch of radial nerve only. And what is this? That's a median nerve ka further branches. So what was that? Radial artery, correct? Brachial artery, two branches, radial artery, ulnar artery. So what is that? That's the ulnar artery, that's the brachial artery, correct? And what was that? Deep branch के ऊपर, which nerve is this? That's the radial nerve. So see this diagram. Basically according to this diagram, this is the radial nerve, superficial branch and deep branch, radial artery, ulnar artery, brachial artery, median nerve between two heads of pronator teres passes deep to deep head of pronator teres. Talking about applied anatomy, so median cubital vein is basically what happens. See, this is our cephalic vein in roof, that's the basilic vein, and that's the medial cubital vein. We have here over here bicipital aponeurosis, and we have over here lateral cutaneous nerve of the forearm, medial cutaneous nerve of the forearm, and we also have a medial these three veins, two nerves, and one bicipital aponeurosis, which forms a roof of the cubital fossa. Talking about applied anatomy, medial cubital vein is fixed on the bicipital aponeurosis via the perforators. Okay, so basically perforators are present which fixes the middle cubital vein on the bicipital aponeurosis. Thus hence middle cubital vein becomes the vein of choice for the intravenous injection. If you want to give in the vein, which vein you will give? That's a middle cubital vein because it's on the bicipital aponeurosis fixed. Workman's ischemic contracture, that is what happens exactly. Supracondylar humerus fracture causes injury to the brachial artery, and this injury leads to basically hypoxia in the flexor compartment of the forearm, and this hypoxia leads to basically contractures. It is permanent shortening affecting more flexors than extensors. This is a very common complication which is seen in case of supracondylar humerus fracture, which will be more detailedly discussed in orthopedics. So yes guys, that was my brief explanation about breast and cubital fossa, which are both of them are very important topics in anatomy. I hope it was a brisk and it was a brief and it was like short and sweet explanation, which is clinical anatomy also explained well. That is, we also discussed like in last Workman's ischemic contracture, in which basically there is a hypoxia of flexor compartment of forearm. Why? Because that flexor compartment of forearm is supplied by brachial artery. If the brachial artery is injured, then no such supply, which will lead to hypoxia, and further hypoxia will basically causes more and more contractions, which will lead to Workman's ischemic contracture. As simple as that guys. Thank you so much for your coordination. Stay tuned, keep listening. Bye.